out there across the country with patient-specific blocks. That's not the one I'm presenting on this morning. That trial's still ongoing. What I'm presenting is my own series with the Zimmer patient-specific blocks. I've got no financial interest with any of the companies that I've been doing these trials with. I think when we introduce a new technology, it's important to always just remember where we are and where we're coming from. And with a total knee replacement, what we're aiming for is a pain-free, stable knee that gives us a functional range of motion. And we don't want to forget that when we introduce something new. We've always aligned total knee replacements back to the mechanical axis of the limb. That's what's been desired, even though there is some push away from that from Stryker to push us towards a different axis. I'll come back to that later. And we can achieve this by eyeballing, conventional instrumentation, which involves intramedullary and extramedullary guides, image-free navigation, or these new image-based navigation, which are the patient-specific blocks. Oops, we can go back one. So all the major manufacturers of total knee replacement now have these systems available. Obviously, the first one on the market was the Signature from Biomet, which has been out for 3 or 4 years now. All the other companies have picked them up. As I said, Stryker's not opened that to the market. I think they'll be coming out in the middle of the year. What this technology does is it relies on the premise of a digital preoperative image, either that be CT or MRI scan of the hip, knee and ankle. What that gives you is a computer model of the knee, its current alignment, as you can see up in the top right-hand side there. I don't know how well that's projected, but that's what the preoperative, that patient was in 7 degrees of Verus. And then from that, you can work out the cuts required to restore the mechanical axis of the leg back through the centre of the knee. Individual blocks are then made for each patient, which guide the distal femoral and the proximal tibial cuts. It can also give you the rotation of those two components and the sizing of the components. Purported advantages of this system is that it gives you accurate pre-op planning, better accuracy to mechanical axis, don't need, therefore, intramedullary and extramedullary instrumentation, removes the need for trackers if you're a navigation or an image-free navigation user, streamline the instrumentation because you know the size of the components and therefore only need to sterilise those trials, therefore a decreased load on the sterilising department and space requirements, quicker setup time for your nursing staff and hopefully quicker operative time. Obviously it comes with disadvantages, and the biggest one will be the cost. The cost of the scans, the MRI scans, is around $380. The blocks themselves that I was using in this particular series I'm going to present are $650, so $1,000 total cost. It's not suitable for all patients, so if you have retained metal wear in the knee or in the leg, obviously can't use it with an MRI scan. If patients aren't suitable for an MRI for any other contraindications that we know. Gross deformity is one that we're not sure of. How far beyond the mechanical axis can we correct back to with these blocks? Revision systems, no, and as John alluded to before, the uni systems have just come online now, and I think John's going to use a few, and I'm just started using a few as well. The other thing to remember is these are non-weight bearing images, and we're not sure what the results are. So on the background of that, I had a look. I got interested in this technology early last year, and I've used the Zimmer patient-specific instrumentation system. The prosthesis is the next-gen high-flex component, which is a posterior stabilised knee. It's a fixed-bearing knee. All components were cemented, and I researched the patella in all cases. So these are the cases that I looked at last year from February through September. There were 44 knees in 43 patients, majority being female, average age 68, minimum 3-month follow-up for this study. They had a clinical evaluation, their Oxford knee scores, SF36 scores. They all had a Perth protocol CT at 3 months. The Epworth Hospital's Research Institute gave me ethics approval to do that, and they had all the radiology, all the CT protocols measured by independent registrars who work with us at Dandenong. I thank Dan and Andrew for their input with doing that. They're the blocks themselves. On the left is the tibial block, on the right the femoral block, and hopefully these videos are going to run for me to show you how they work. The video on the video on the left, once standard operative approach to the knee, the block itself on the femur fits with 4 components that fit onto the, well, 2 onto the anterior cortex of the femur and 2 onto the distal aspect of the femur. There's 2 pins which hold it on the anterior cortex of the femur, which your assistant will tap in for you. Then drill these 2 holes on the front of the, or on the distal aspect of the femur, which guide the rotation. So once that block is drilled and put on, it can then be removed fairly easily. If we move to the next video, when you can then put on your standard cutting block and assess where you're at. So you do get a visualization to see whether you're taking too much off, whether you look to be in too much varus or valgus, and then put a locking or a cross pin into that block and cut through that. Just showing on that video, the checking to make sure that you are hopefully where you appear to be. You can still use your visual cues to make sure that you're happy. The last video is for the rotation. So those 2 pins are then reinforced. Once you've cut the distal femur, you put those 2 pins back into those 2 pinholes, put the 4-in-1 cutting block on, make sure it's in the right spot, and then cut your Similarly with the tibia. Now the tibial block is a little bit harder to get on. Particularly, this video doesn't show it very well, unfortunately. It'd be better to look from above, but there is a little finger that goes over the back of the medial tibial plateau. That's important to get that over the back of the tibial plateau and down. This is a Monday morning case. You can see I had a couple of goes at getting that in. So again, you pin the block as normal, as with the femur, remove it, and then put your standard cutting block on and cut through there. And I'm sure a few in the audience have tried these blocks. So if we turn to the results, looking at the clinical results first, the SF36 scores, you can see there was improvement in all of the things that are measured with that scoring system at 3 months. Oxford knee scores improved from 19 to 42 on average post-operatively. In terms of the tourniquet time, one of the purported advantages of this technique is that you will be quicker. So for these PSI, for these blocks, my average tourniquet time was 70 minutes compared to a navigated knee. So I took a matched group of my previous patients who had a navigated knee, and that was 83 minutes. And also looked at an instrumented group, and that was 78 minutes. So it is quicker, though not excessively quicker. Range of motion, pre-operative 5 to 105 degrees and post-op 2 to 118 degrees was the average. In terms of the component sizing, it's important to look at that graph on the left. With the femurs, the blue bar graph hasn't come out too well, but that's the correct sizing. So close to 90% of the femurs were the correct size. There was 1 that was undersized and 2 that were oversized. So I think overall with the femurs we had good results. Tibias were terrible. The tibias, the correct sizing was less than 40%. They were mainly undersized. Half of them were undersized, and I'll come back to why that was in a moment. In terms of the poly thickness, 75% of them with the 10mm poly thickness that I planned to put in. A quarter of them, 25%, I need to upsize to a 12mm thickness. We look at the results from the CT Perth protocol. So if we're looking at the mechanical axis, their alignment back to coronal alignment, they are clustered around neutral, which is pleasing to note. So if we look at a bell curve within plus or minus 3 degrees varus valgus of neutral, I only had one that was 4 degrees varus. There were one that was 4 degrees valgus and 2 that were 5 degrees valgus. I'll come back to those in a moment. In terms of the posterior slope of the tibial component, we're aiming for 5 degrees with this particular prosthesis. Again, the results are clustered around 5 degrees, but we do have a range all the way from 1 degree of posterior slope through to 8 degrees of posterior slope. And the femoral rotation in terms of the epicondylar axis. So we're trying to get back to neutral compared to the epicondylar axis. There's a bit more of a spread here across so we don't really have a nice bell curve centrally around 0, but from a range from 3 degrees of external rotation to the epicondylar axis, 4 degrees of internal rotation. In terms of complications, there was no surgical complications in this group. There was one lady who had a CBA 10 weeks post-op and ended up in a nursing home. She was excluded from her any further follow-up. There was no infections, DVTs, PEs, no manipulations needed to be performed, in particular in relation to the blocks. There were no breakages or no oops moments in the theatre where I dropped it. If I come back to the summary of those component sizing, as I said, the femurs were good. They were 88% correct. The tibias were poor. The majority were undersized. This is the graphic that you get prior to the surgery. I think if we all look at that graphic, this green bit here is the overhang. The algorithm for the computer does not allow any overhang. So if that was the planned size, it would have downsized from that component. And I think if we all look at that component on the cut surface of the tibia, we'd all not want to put it there. That's sitting on cancellous bone. We'd prefer to sit it out here onto the cortical bone all the way around. So it does give you this error message that, or this warning message that you may be overhanging, and do you want to carry on with that component? And as I went on with this series, I did upsize my tibias, and hence that's why there were 4 tibias that were upsized in that overall summary slide. But as I said, the algorithm does not want to have any overhang whatsoever, and will tend to downsize the components. In terms of the positioning, in terms of the coronal alignment, as I said, there were 2 knees that were in 5 degrees of valgus, 1 in 4 degrees of valgus, 1 in 4 degrees of varus. So of the 44 knees, there were 4 that were probably considered outside the acceptable range of coronal alignment, which is 9%. The slope of the tibial component, as I said, the range was 1 to 8 degrees, and the femoral rotation, 3 degrees to 4 degrees internal rotation. Measuring them off the Perth protocol is not an easy thing to do because there is scatter, obviously, with the components. So if I compare that to what else has been published out there, obviously this is a very new technique. There was an article published in the Journal of Arthroplasty just last month in relation to the Visionaire system from Smith and Nephew. This paper was very short on detail. All it gave was their results being 0 to 6 degrees in their range of coronal alignment, didn't say whether they're in varus or valgus, and gave the average of 1.6, and said therefore they were better than their 2.7 average as opposed to conventional instrumentation. Signature paper that was published late last year in Clinical Orthopedics, interestingly they had pretty much the same result as myself. They had 9% of their blocks which are outside that 3 degrees of varus valgus range, and that's in comparison to 22% with conventional instrumentation. Neither of these papers mentioned slope or rotation. So to turn to discussion, obviously what I presented to you this morning, this is just there are some weaknesses, retrospective single surgeon case series, no control group, it's only a short follow-up of 3 months, and they are non-weight bearing radiological review. To come back to those purported advantages and whether I achieved them or at the end of the day, does it allow preoperative planning? I gave that across. I think the tibias were poor with that. Once I recognised that we did need to upsize them, maybe we could give that a tick. But overall, not on the results that I've looked at today. Does it give better accuracy to the mechanical axis? I don't think we can say that. We can say it's at least as good as conventional navigation. It's certainly no worse. It does remove the need for intramedullary and extramedullary instrumentation, therefore the canal's not breached. You don't need trackers, pins, and the clumsiness of image-free navigation systems. Streamlined instrumentation, I gave them across for that because if we did dumb down the instruments according to, say, a size 3 tibia, we often had to open the next set or to upsize, as I did through a lot of the cases. There is a decreased load in the sterilising department though, because once you've got that dumbed down set, that's all it needs to go through. It's a much quicker setup time for your nurses, and the operative time was quicker. So to summarise, the results are better than conventional instrumentation. If you look at this, this is a meta-analysis paper back in 2007, where 20 to 30% of conventional knees were outliers from 3 degrees of varus valgus. In terms of image-free navigation, we're about the same, 5 to 10%. Does give you better intraoperative efficiency, which must benefit the patient, less time under the anaesthetic. It benefits the hospital because you get through the list quicker. Probably benefits us because we can put an extra case on the list. But does it justify the cost? It's $1,000 per case to do this. And I think it's very important to remember that these are guides only. And so if you put the guide on and you're not happy with its position, you do need to revert to another system. That would probably be the instrument.
Thanks very much, Bob.